Efficacy of botulinum toxin type A in the treatment of essential blepharospasm and hemifacial spasms. Dr. Meghana Tanwar.
Good afternoon, everyone. I'm Dr. Meghana Tanwar, and I'll be presenting the paper titled Efficacy of Botulinum Toxin Type A in the Treatment of Essential Blepharospasm and Hemifacial Spasms. I have no financial disclosure. So facial dystonias are a group of disorders characterized by involuntary spasm of the muscles of the face and the neck. These disorders may be idiopathic or secondary to compression or a pre-existing palsy of the seventh nerve. Although there are surgical and non-surgical modes of treatment, type A botulinum toxin is perhaps the most popular treatment as of now. There are various preparations which are commercially available, but a unit of a given preparation is not comparable to a unit of any other preparation because of the differences in molecular dilution schemes, laboratory protocols, and differences in species sensitivity. So there's no common normogram which can safely be used with all variants of botulinum toxin. As most studies performed used on botulinum toxin A, Botu gene obviously would have a different pharmacokinetic and dynamic profile. Hence, we decided to find out if Botu gene is efficacious and safe to use in facial dystonias and determine the factors which alter its efficacy in our population. The study was conducted at the Department of Orbital and Oculoplasty at Aravind Eye Hospital in New Delhi, and the patients with idiopathic or secondary facial dystonias were studied from a period of the 1st of May 2016 to 30th April 2017. It was a retrospective study which included patients with primary or secondary facial dystonias who had been receiving injections of botulinum toxin in our hospital and had received at least one injection during the study period. Any patient who received a variant other than Botu gene before or after treatment with us was excluded. So we used Botu gene in all cases, and it was reconstituted to 25 or 50 international units per ml depending on the severity, and 0.1 ml was injected at each proposed site. The dose varied according to the pre-injection severity and resistance to therapy. The data collected was demographic profile, pre- and post-injection severity of symptoms, details of the injection, progression of symptoms, duration of the symptom-free interval after each sitting, and complications noted on the 7th post-operative day. Statistical analysis we used a student t-test, square test, ANOVA, Spearman's rank coefficient, and a p-value of less than 0.05% was considered statistically significant. Coming to results, the total number of participants we had were 26, and 76 sittings were studied. The mean symptom-free interval was 139.92 plus minus 58.53 days, and there was no statistically significant difference between primary and secondary facial dystonias in terms of distribution of age or gender. This graph just shows the distribution of the patients that we studied, 23 of which had hemifacial spasm and 3 had zental blepharospasm. There was no significance in between distributions of phenotypes and between primary and secondary facial dystonias in terms of duration of illness in years at presentation and modal disease severity at presentation. So the symptom-free interval was unaffected by gender of the population or duration of disease at presentation, and there was but there was a longer disease-free interval in primary dystonias as compared to secondary dystonias. There was no statistically significant difference in correlation between the total dose of the drug administered in a sitting and how long the patient was symptom-free. The symptom-free interval, however, increased significantly in subsequent sittings when the total dose per sitting given was 22.5 international units. At other doses of 20, 25, 30, and 50 units, there was no similar increase in efficacy seen. And between primary and secondary dystonias, we did not see any significance in the complications that we saw. So coming to discussion, the mean symptom-free interval post-injection in our study varied from 3.4 plus minus 4.9 months, which is comparative with reports of Wang et al. And slightly greater than the ones reported by Anwar et al. There was no statistically significant improvement in the efficacy of drug on increasing the dose, which was similar to studies published previously. There was statistically significant increase when the dosage given was 22.5, which can be explained by the fact that the severity of spasm at every visit was seen, and we switched to a higher dose when the spasms were resistant to the previous one. As a result, the patients receiving the lower dose actually had less resistant disease and hence maybe were symptom-free for a longer period of time. Now, the first injection of botulinum toxin was associated with a longer disease-free interval in primary than secondary dystonias, which has been published in earlier studies because of stronger compression forces. Now, in our study, the commonest complication was lag of thalamus followed by deviation of angular and ptosis, where different reports have different complication profile, which can be explained by the different dosage schedules and slightly different techniques. In conclusion, I would like to say that botulinum toxin type A is both safe and efficacious in treatment of facial dystonias, slightly more effective in primary than secondary. Nevertheless, keeping the complication profile in mind, I'd like to suggest botulinum toxin A injections as the primary modality of treatment in forms of facial dystonias. Thank you.